Thank you very much for the introduction. And I want to thank the organizers very much for inviting me to give this keynote lecture. It's a great pleasure and a great honor being here, with my favorite topic for the time being, tomosynthesis. Should it be integrated into screening and clinical routine imaging? So the objective of this talk is, what is digital breast tomosynthesis? Many of you know that already. Some of you will not be aware of what it is. Then discuss tomo in the clinical setting, the potential implementation of tomo in breast cancer screening. I will go into the synthetic 2D mammograms, present some of the main findings of our tomo trial in Oslo, and a brief overview of trials in the screening setting so far. What is tomosynthesis? Many of you, maybe the older ones, think tomosynthesis, the name sounds like the good old conventional tomography that some of you used in urography years ago. You know, the conventional tomography, a movement of the X-ray movement, we get slices through the breast. How does it work? You can see the X-ray source, the moves around and makes several low-dose projection images. And these low-dose projection images are reconstructed into a stack of images, often 1 millimeter thin slices. The dose is the same, approximately, as a conventional 2D. So far, there has been several studies, mostly experimental clinical studies, comparing conventional 2D images with DBT. If we should draw a conclusion regarding microcalcification so far, we can say that tomo is at least equal or comparable to conventional full-field digital mammography. Tomosynthesis is superior to digital mammography regarding cancer size assessment and the question of multifocality in the breasts. Tomo is superior regarding the specificity, and it seems from studies published the last couple of years that tomo may replace supplemental diagnostic views, as MAG views and countdown views, for non-calcified lesion. This opens, of course, for more effective work in the clinical setting and lower radiation dose to the women. And important, especially for breast cancer screening, tomo has an increased cancer visibility and conspicuity as compared to digital mammography. Let's look at these aspects. Microcalcifications. Be aware that on these 1 millimeter slices, you occasionally see only some of the microcalcifications, not all that you can see on a projection 2D image. That means we have the so-called thin slice effect. But we have the possibility on the workstation to merge slices of 1 millimeter into so-called slabs. We can define in 2 millimeter slabs, 5 millimeter slabs, 10 millimeter slabs. But our experience in Oslo is that we gain, in fact, little information from these slabs, so we do not use it very often in Oslo. Tomo is superior for the assessment of cancers, cancer size, especially dense breast parenchyma, and for multifocality. I show you one case. On the conventional 2D to the left, we, of course, easily see this speculated mass in the fatty part of the breasts medially. On tomo, we see it better, more convincing, but there is no new information. The new information on tomo is that you also see a spiculated lesion in the lateral part of the breast. Even in retrospect, when you know here is a small spiculated mass, even in retrospect, I think you must admit and agree with me that we cannot make a suspicious cancer diagnosis on the conventional 2D. This is, of course, in another plane as the cancer medial. So, tumor assessment, measurement of size and multifocality DBT is superior to conventional digital mammography. Increased specificity. We can see on the conventional 2D there is mass, but the borders, the shape might be very difficult to analyze in a dense breast parenchyma. On the tomo, we can sharply see it is absolutely benign appearing mass with a halo, no calcifications. So the specificity is increased using tomo. So if there are any masses, is there one, is there two, are there three? On tomo, we can increase the specificity. Important is that the cancer conspicuity is much better on tomo as compared to conventional mammography. In retrospect, there is a poorly defined density in the posterior aspect of this breast, but to make a cancer diagnosis on the 2D is very difficult or not possible at all. If we look at the corresponding tomosynthesis, you can see a spiculated mass in this area. It was a tubular carcinoma, 6 millimeter in diameter on histology. This lady was from our pre-screening study, and she was called back from a screening due to these microcalcifications that you can see in the retroareolar area. That was the reason for diagnostic workup and assessment. We did a biopsy of that. It was benign, these calcifications. We did standard additional views. We did ultrasound, and the woman was discharged. The microcalcifications benign, and after she had left the department, we looked at her tomosynthesis, and you clearly see a spiculated mass in this area. Even in retrospect, when you know there should be a spiculated mass in this breast, it is impossible to identify the lesion on conventional 2D. So cancer visibility is heavily superior to digital mammography. In dense breast parenchyma, it might be difficult to identify these speculation lesions. What we see is, of course, the speculation. That means the desmoplastic reaction around these cancers. And if there is absolutely no fatty tissue surrounding these lesions, we may have problems of seeing these fine speculations. So in the very dense breast, ACR4 breast, for example, I think that perhaps ultrasound will still be superior to tomosynthesis in most cases. People usually said in the absolutely fatty breast there is no gain of using tomo. It is partly right, but I show you just one case from our trial. This is a radial architectural distortion. We see it clearly on the tomosynthesis. It is very difficult to see on the conventional 2D. I'll show you this case just to remind you, even in fatty breast, occasionally you detect more on tomosynthesis. This was a radial scar, so it was in fact a false positive, but I just show you the lesion to remind you of the superiority of tomosynthesis. So the great challenge, as I see it, is implementation of tomo in a screening setting. That is the great challenge. And one main question that we had for several years is, do we need two-view tomosynthesis? Could you use one tomo view? and perhaps conventional FFTM in the other view? Should we use two-view conventional 2D and Tomo, or do we need two-view FFTM and two-view tomosynthesis? If we would need two-view Tomo in addition to two-view FFTM, that means we would double the radiation dose to the women, and that would not be acceptable in daily practice. In a population-based screening program, that would not be acceptable. Do you see the distortion on this in this case? Left, you have a conventional 2D. To the right, you have a tomosynthesis. You have a perception problem in this case. It is not so easy to detect these abnormalities. Some of you, especially if you have a little experience in Tomo, you will see it, but in a batch reading, when you have a heavy workload, it might easily be overlooked on the MLO view. So it is not so easy to see it. If you agree with me, it is there, but it might be missed in a day with a heavy workload. On the CC Tomo, on the other hand, there is no reason to miss it at all. We clearly see it. I'll just show you this case. So our experience is, after 3 years with Tomo in Oslo, we should use it in two views. And I'm happy that we decided before we started the Oslo trial to go for two-view tomosynthesis in our screening setting. The question is, of course, do we need 2D? Theoretically, if you have 1 millimeter slices through the breast, can't you see everything? Do we need any more 2D images? I think we do need it. I do think the radiologists want to have projection images. First, we would like to compare with prior examinations. We want to compare current with priors. And it is so important that you always compare right with left. Right with left are the any asymmetric density and so on. We had it in our workshop this morning. And it might be that your examination are requested from other hospitals that do not have tomosynthesis. Overall, in summary, there is many reasons that we really need that we need projection 2D images. But a projection 2D images plus Tomo would mean a doubling of the radiation dose, not acceptable in a population-based screening program, and the solution to this problem are synthetic 2D images. What is a synthetic 2D images? We do have the 3D data set from the tomosynthesis. And from these 3D data sets, we have reconstructed synthetic 2D images. So the questions are the synthetic projection images good enough for our daily practice? How does these synthetic images look like? To the left, you have a conventional 2D image. On the right, you have a synthetic 2D image. You see, depending on which algorithms the manufacturers are using, you will get some artifacts. We may have artifacts from macro calcifications and so on, but in general, we had the old version during the first year of our trial, and it has no practical importance regarding the evaluation of the images. For larger cancers, of course, there is no problem with these images. To the left, you have conventional 2D images. Here in the middle, a synthetic 2D image and the corresponding Tomo slice. You see the cancer more nicely on the Tomo slice, but there is no problem with the diagnosis on the two other images. So smaller cancer, but as masses, we do not expect any problem with synthetic 2D images. But how about these finer lesions? And interestingly, the speculations, which are so important, they are in fact better seen on synthetic 2D images than on the conventional FFTM. Look at this case, an invasive lobular cancer, 12 millimeter. On conventional 2D, it is very difficult to see it when you know the tomo finding, okay, and you go back, you will see, okay, I can see this small lesion, but in a batch reading mode, in a daily setting, you easily miss that cancer. You see it clearly on the tomosynthesis. You see it on the synthetic 2D image much better than you do on the conventional FFTM. I mentioned to you the thin slice effect of tomosynthesis. How about synthetic 2D and microcalcifications? I show you one case. These very, very small, fine punctate microcalcifications may occasionally represent a perception problem in the very dense breasts. On the tomo, I mentioned we had the thin slice effect. You see only some of these microcalcifications. On the synthetic 2D images, on the other hand, you do have a highlighting of the calcifications. That means the perception or the detection of microcalcification is improved on synthetic 2D images, but not the characterization or analysis, but the perception of these calcifications. So what about the combination? I show you one case. It was a DCIS. In this case, you see a mass. What do you have on the conventional 2D? That is what we have here to the left. And this is approximately the same radiation dose. Using tomo, you have a synthetic 2D image, and you have the tomo. And if you add the information on synthetic 2D, that means the highlighting of the microcalcifications. You get the distortion on the tomosynthesis. So you get this important information for the same radiation dose as the conventional, and on the conventional 2D in this case, you could miss the fine microcalcifications as well as the distortion or radial architectural distortion. We would expect that the producers will ongoing improve the algorithms for synthetic 2D interview. We had the old version during the first year of our trial in Oslo. You see one case with the old version of synthetic 2D, and you see to the right the new version of the synthetic 2D. The speculation, this desmoplastic reaction around these small cancer is much more obvious and clearly demonstrated on the new version of the synthetic 2D images. The same in this case. To the left, I show you the old version. Here you can see the new version. The fine speculations are much better seen. So it is to expect that there will be an ongoing improvement of these projection images, also these synthetic views. Okay, so that means that it should be possible to implement tomo in screening setting with the same radiation dose that we have for conventional 2D images. And that was the background for our Oslo tomosynthesis screening trial. It is not so easy to understand these trials, and since we have 3 publications so far and there will come more publications, I want to go through this study design with you. You should know that this Oslo trial was scheduled for 1 screening round in Oslo. And 1 screening round, we have biannually screening also every 2nd year. So it was scheduled for 1 screening round or 2 years. I estimated that we will have about 25,000 women having tomo during these 2 years. We ended up with 25,500, so that was very close to my estimates. We started the study on November 22, 2010, and the study was closed on December 21st, 2012. Our screening program in Oslo is part of the Norwegian breast cancer screening program. Women 50 to 69 years are invited for a 2-view mammography every second year. We have independent double reading with consensus or arbitration. We are using a 5-point rating scale for probability of cancer. It is not identical with the BIRATS categories. And we are online reporting the results directly into the central database of the Norwegian Cancer Registry that has the audit of the screening program. So what was our intention with the Oslo Tomo trial? All women attending the screening unit were invited to participate in the study. We excluded women with implants, and we excluded women with pacemakers. And if the women were heavily disabled and couldn't stand, we examined these women in our clinic and not in the screening units. But basically, all women were invited to participate if there was availability of the radiographers and availability of equipment. Very few women declined to participate in the study. In most cases, it was the availability of radiographers that was the limiting factor, not because a tomo takes much more time. It takes only 4 or 5 seconds more time for review, only 4 or 5 seconds. But of course, when the women are participating in a trial, they have more questions and they want to know what it is, so it takes overall a longer time for the radiographers. So women who were included, they got conventional 2D plus tomosynthesis, and the women that were not offered the tomo, they underwent the conventional in 2D as they were scheduled to have it. I need to mention to you that we had a common consensus or arbitration meeting. It is important that you are aware of that. It was due to our capacity. We nearly broke our neck with 4 arms, and if we should have 4 separate arbitration meetings in addition to 4 arms, we would never have been able to complete this heavy trial. So we had a common arbitration meeting. That means we have to look at the positive scores, not the actual recall from each of these arms. And you should also notice that we slightly modified the 2D arm and the 2D plus tomo arm. In this independent double reading, one of these independent readers had only conventional FFTM, also digital mammography. In the other arm, it was FFTM plus computer-aided detection. In the 2D plus tomo arm, one reader had the conventional FFTM plus tomosynthesis. And in the other arm, we replaced the conventional 2D with the synthetic 2D. So it was a slightly modification. We had four viewing stations in 4 different rooms. And when one reader logged into one of the arms, the other arms were automatically blocked. So it was an absolute independent reading in all 4 arms. What have we published so far from this trial? If some of you read the first paper published in Radiology last year, comparison of digital mammography alone and digital mammography plus tomosynthesis in a population-based screening program. What did we do? We did compare the clean FFTM arm, also the clean digital mammography, with the clean, you may say, FFTM plus tomosynthesis. That means the single reading in arm A versus single reading in arm C. What did we find in this study? I will not go into details, but the malignancy rate was very high, what we detected, but if we split up into this arm A versus arm C, that means the clean digital mammography versus clean 2D plus 3D, this arm detected 77 cancers, and in 2D plus tomo, 101 cancers, for a detection rate of 0.61% versus 0.80%. That means the relative increase in the cancer detection rate was 31%. What type of cancer did we pick up more commonly on 2D plus 3D as compared with the 2D alone? You can see, interestingly, there are no more DCIS. The number of DCIS in both arms are nearly identical, one case difference only. So what we pick up are cancers manifesting as speculated masses and the cancers presenting as distortion. In the second paper published in European Radiology, also last year, what did we do in this study? In this study, we compared the independent double reading, having only 2D, versus independent double reading 2D plus tomo. Keep in mind, one arm had CAD in this reading mode, and one reader or one arm had a synthetic 2D in this arm. What was the main finding in this study? You see exactly the same. 32% more cancers. Also, there was a relative increase in cancer detection of 32%, and again, there was cancers manifesting as speculated masses and distortions mainly, or in this case, interestingly, also some cancers manifesting as a microcalcification within an asymmetric density. And we can see the mean size of the additional cancers were 10.7 millimeter in size. There was a huge range, and you can see that about 50% were low-grade cancers, 14 versus 16 high-grade, also grade 2 and grade 3. I'll show you some examples. The reader scores at the bottom, 4 independent readers, are only FFTM. B is the conventional 2D plus CAD. That was the pure 2D plus tomo and synthetic 2D plus tomo. You can see in this case, only one, interestingly, only one of the two readers picked up these cancers. You can see the fine speculations in the left breast on MLO tomo. In retrospect, it is not possible to see it. You have an absolutely non-specific asymmetric density in this area, but the speculations itself is impossible to see on the 2D image. You know this case from our workshop this morning, so I will go fast through it. You see the distortion in this case, and on tomosynthesis, you clearly see the distortions that is not visible on the 2D image. I also stressed this this morning, the observer variability in screening from our publication a couple of years ago. More than 1 million independent double readings in the Norwegian breast cancer screening program, more than 5,600 screening detected cancers, and if you just look at this arm, in about 33%, the cancer was only detected by one of the two independent readers. If we look at the cancers from the publication in European Radiology, and we look at the cancers picked up by the readers in arm A, that plus B, that means 2D only, versus 2D plus tomo, you can see the discordant cancer interpretation rate is approximately the same that we had in the Norwegian screening program, about 25%. are discordant interpretation, that means missed by one of the two readers. Interestingly, if we stratify and look on only the additional cancers found on tomosynthesis, also negative on independent double reading with conventional 2D, and picked up positive only by at least one of the two readers having 2D plus tomo, you can see that the discordant cancer interpretation rate was 68%. This is an interim analysis. I will not say this is going to be the final results in the Oslo trial. But what does it tell you? It tells you that the perception, detection, and the analysis of these fine additional cancers that you pick up on tomosynthesis are not always so easy. You definitely have a learning curve. It might occasionally be difficult to see, is there a radial architectural distortion, or is it only crossing connective tissue? Do I see it only on one view, or are it on both views? It is not always so easy. So without doubt, this high discordant rate indicates you have a learning curve regarding interpretation of tomo findings. I think the last paper, it is online published in radiology, so you can find it there. It is 2-view digital breast tomosynthesis screening with synthetically reconstructed projection images, also synthetically 2D. What did we do in this study? We compared arm C with arm D, also conventional 2D plus tomo versus synthetic 2D images plus tomo. I'll show you this example. You saw it this morning. In this case, you see the speculated mass easily on tomo. You see it easily on synthetic 2D, but you will miss it on the conventional 2D. In another case from a dense breast, on tomosynthesis, you can see this 12 millimeter grade 2 invasive ductal cancer with the speculations quite easily. When you know the tomo finding, you may suggest that perhaps it is visible on the synthetic 2D, but it is definitely not visible on the conventional 2D. It is a non-specific density in that area, but you cannot make a cancer diagnosis out of it. And you can see at the bottom the scores of the 4 independent readers in the Oslo trial. The cancer was missed by both readers having only 2D. It was picked up on our 5-point rating scale by both readers having 2D plus tomosynthesis. So what were the main findings in this publication? And I think this is very important. There is no significant difference in the positive scores between conventional 2D and synthetic 2D. There is no difference in the cancer detection rate between conventional 2D and synthetic 2D. And there is no difference in the positive predictive value between conventional FFTM and synthetic 2D. But I want to underscore, in combination with tomosynthesis, I will not say that per today, synthetic 2D as a stand-alone diagnostic tests, that they are good enough. But in combination, and that is my message, in combination with tomosynthesis, we can use synthetic 2D images. Also, one example from our screening program. In this case, you might see the speculated mass in a very dense breast picked up by one of the two readers having only 2D, but you see both readers with 2D plus tomosynthesis give a score 5. In this case, this is quite easily in the dense breast. The question is, okay, fine, that's fine. We can use 2D or synthetic 2D plus tomo in the screening setting, but how about the interpretation or reading time? Time is money for everybody. How much more time do we need to do the reading over these tomosynthesis images? I'll show you our hanging protocol. how we use it in Oslo. Before we started the trial, I made a suggestion for a hanging protocol. I said to my colleagues, if you have any improvement or suggestion for a better hanging protocol, I will listen to you. Otherwise, you have to do what I say and use this protocol. First step, prior CC back-to-back, current CC back-to-back. Prior MLO back-to-back, current MLO back-to-back. Only to see, are there any developing densities? Are there any developing mass? I'm not looking at all for details on this first step of the hanging protocol. Just, is there anything that is developing in the right or in the left breast? And then the current CC back-to-back, are there any differences? MLO back-to-back, as a current. And then we move to the tomo, and we always have a 2D images on the left screen, and we scroll through the tomo on the right screen. So regardless whether we use conventional digital, also FFTM, or we use synthetic 2D, we have the projection image on the left screen, and we scroll through the tomo on the right, starting with the right breast in CC projection, go on with the right breasts in MLO projection, 2D image on the left screen, tomo scrolling through on the right. Then we move to the left breast, CC, and CC MLO. And the first step, once again, at the end, did I miss any developing densities or developing masses? Of course, the advantage of using such a hanging protocol is, of course, if you see something on the tomo, you can immediately compare it with the 2D. We had an automatic interpretation recording in our Oslo trial. That means when a reader logged into a case, the seconds was automatically recorded by the computer, and it was stopped when he clicked the conclusion. So all the readers in all arms were automatically recorded. I'm very happy and grateful to my colleagues for accepting that. I stratified on the 6 months periods of our 2 years trial, and you can see when we started the study at Christmas 2010, the median interpretation, this is not the mean, but the median, of course, you know, from daily practice, you get phone calls and you get coffee breaks. So if you take the mean, you have some outliers that are heavy. So these are the median reading time, 74 seconds. But after 1 year, it dropped to approximately 60 seconds. So you have to compare these 60 seconds with the 25 seconds, which is the average median reading time in Oslo. I think 60 seconds is a little fast, but that is what it turned out to be. There has been one publication from the Italian group in Trento Verona, Daniele Bernardi, and they reported an interpretation time of 77 seconds. So we can say 60 to 90 seconds in that range. So, of course, you have to wait an increase in cancer detection of 30% against the increased time of interpretation from 25 to 70 seconds. I show you one case from our Oslo trial. This cancer missed by both readers having only 2D and missed by one reader having tomo, but picked up by the other reader having tomo. You see the interpretation time, 300 seconds spent the radiologist having arm D that day. These readers spent 34 seconds for that case. Of course, it is a bad job. It is just too fast reading. You cannot go through this hanging protocol in 34 seconds. So this is obviously a perception error due to too fast reading. There have been some publications on tomo in the screening setting so far. I will not go into detail of this study, but you should keep in mind that the design of these studies are very, very different, and consequently, it is very, very different to compare the results of these trials. The first publication was from Trento Verona, the Italian storm trial. That was a prospective paired study using 2-view 2D and 2-view Tomo, but they had double reading, but it was sequential reading. The Oslo trial had also 2-view 2D and 2-view 3D. It was also a prospective and paired study, and we had independent double reading in the Oslo study. The 2 US studies, of course, as in the US common, it was single reading, but they had also 2-view Tomo in their setting. We are all waiting for the Malmö trial that I hope will soon be published, at least an interim analysis. They have also double reading, but they have only 1-view Tomo, as far as I know, and they also have sequential reading as in the Trento, as in the Italian storm trial. So keep this in mind when you compare results of the different studies. The design is very difficult. It is nearly impossible to compare the results. But if we should try to compare the results, I will say the main message is, regardless which of these studies you look at, there is a significant, except for one study, and that was the Yale New Haven Connecticut study, except for this study, there is a large increase in the relative cancer detection rates. That is, I think that is the main message. So to you all, take-home messages. In the clinical setting, I think tomosynthesis has proven superior to conventional FFTM for cancer size assessment and assessment of multifocality and the evaluation of non-calcified lesions. The replacement of supplemental views may reduce your examination time in the clinical setting, and it will reduce the radiation exposure to your patients. In mammography screening, 2D plus Tomo significantly increase the cancer detection rate. That means significantly increase the sensitivity as compared with digital mammography alone. And tomosynthesis plus synthetic 2D images make the combined use of 2D and 3D possible with approximately the same radiation dose as conventional FFTM. We do have the inter-observer variability problem with Tomo in screening, as we had it with the screen film and as we had it with digital mammography. That is in fact the largest challenge of screening, that is the inter-observer variability in reading the films. I think personally that the additional interpretation time for picking up, if it proves to be true that we pick up 30% more in invasive cancers, I think the use of Tomo is justified. So many thanks to you for attending this session late in the afternoon, and thanks to the screening team in Oslo for the great job they did for our trial. Thank you very much.